Hello, and thank you for joining us today for Sustainable Strategies for Asthma Care, Best Practices from the 2018 Asthma Award winners. This is a web-based presentation sponsored by the U.S. Environmental Protection Agency. As Eileen said, I'm Tracy Mitchell, and I will be your moderator today. And I'm pleased that so many of you could be with us to hear about this year's award-winning programs. The Pediatric Asthma and Allergy Clinic, also known as PAC, at Zuckerberg San Francisco General Hospital, and the Community Asthma Prevention Program, also known as CAP, at Children's Hospital of Philadelphia. Before we get started with today's presentation, I'd like to get a sense for who's in the audience today. So to do that, please take a moment and answer the polling question that you see on your screen. What type of organization do you represent today? Please let us know now. Great. So it looks like we have great representation across the board. Many of our federal and government colleagues are with us today. It looks like the majority of you are healthcare providers, which is very exciting because you're going to hear from two dynamic healthcare providers. We have some health plan representation, community-based programs, and then about a third of you classify yourself as others. So there's a little bit of something for everyone in today's presentation. I'm confident of that. One more quick question. What actions are you already taking in pursuing sustainable financing? I know many of asthma programs across the country are looking for ways to sustain and to achieve sustainable financing. And so we've listed here some of the common approaches and strategies that we're promoting and helping communities promote. So please choose one. If you're currently not in a position to pursue sustainable financing, please choose none of the above. Great. And what we see is a large majority of participants, over 40%, chose none of the above. But many of you are working already in partnership or exploring partnerships with programs in your community, as well as reaching out to state and local agencies. So I think you'll hear from today's programs ideas, strategies, and ways that you can actually pursue sustainable financing in all of these areas. So I'd like to just briefly go over our agenda for today. Both of our award-winning programs are recipients of the EPA's National Environmental Leadership Award in Asthma Management. So I'd like to just talk a few minutes about that award and the program, and then talk about it in the framework of EPA's system for delivering high-quality asthma care. This is a framework that many of our award-winning programs use not only to develop and to sustain their program, but also many of these program components are reflected in their application. So we'll talk a little bit about that. Then we'll turn it over to our speakers who will dive into their program strategies for sustainability, including the use of community health workers and building local partnerships in order to strengthen their community ties. As we've already heard from Aileen, the webinar Q&A will be immediately after this presentation on AsthmaCommunityNetwork.org. Go ahead and go to the next slide, because for many of you who may not have joined us in the past or joined our Q&A sessions in the past, what we're going to do is have our speakers available from 2 to 2:30 for live discussion forum, for a chat session where you can ask your questions virtually online, and they'll be available to answer you in real time. So what is important is that you are a member of Asthma Community Network. And hopefully many of you are already members and able to sign in. You may want to try to do that at some point just to make sure you can log in. If you can't, let us know. We can get you your password reset very quickly. And if you're not a member, you're also able to very quickly and easily join Asthma Community Network. When you get to the homepage, there's a discussion forum link, and you'll click on that where it will have today's date for the webinar, and you'll be able to post a question and then just be sure to click save, and that question will be there for our presenters. You can post questions actually during the webinar, or as I said, our speakers will be available for 30 minutes after the webinar. So let's just talk a minute about our learning objectives and what we're going to accomplish today. Key takeaways for today, you're going to hear from our two winners about the successful strategies they've employed for not only addressing asthma triggers, but engaging community health workers and pursuing program sustainability. Each of the programs will share how they built partnerships within their community and community organizations, including local school districts and other organizations, and how strengthening community ties really helps to improve comprehensive asthma care. You'll understand how each of these programs effectively tracks data to measure key program outcomes and ultimately cost savings. And then you'll discover their program strategies for pursuing reimbursement through Medicaid and from health plans, which is very exciting. So as I said, I'd just like to take a moment to tell you a little bit about the award, or remind folks about the award. The National Environmental Leadership Award in Asthma Management is the highest recognition in the country that a program and its leaders can receive for delivering excellent environmental asthma management as part of comprehensive care. Applicants undergo a two-tiered review process conducted by representatives from federal agencies, that's EPA, CDC, the Centers for Disease Control, NIH, HUD, and organizations like America's Health Insurance Plans and the Allergy and Asthma Network, as well as other experts in asthma management. The expert panel comes together, reviews the applications, and chooses the best applications that meet the published criteria on AsthmaCommunityNetwork.org. We will be launching the competition for the 2019 award probably this fall, so I'll encourage you to stay tuned and to monitor Asthma Community Network for that information. So since 2005, EPA has recognized health plans, healthcare providers, and communities in action for their best practices and approaches to delivering comprehensive care, which, as I said, includes a robust environmental trigger component. This year's winners, CAP and PAC, join over 40 programs across the country who are models of excellence in asthma care. And so I invite you, if you haven't visited the Hall of Fame on Asthma Community Network, to do so and to read and learn about all of the stellar programs that have been awarded through this competition. As well, many of our previous award winners have participated in webinars similar to today's, and those presentations are archived on Asthma Community Network. And so you can access those former presentations for former previous webinars on Asthma Community Network. As I said, besides being placed in the Hall of Fame, the winning programs receive national recognition through a press release and blogs and other social media. Winners receive a crystal and an opportunity to serve as mentors to other programs across the country to achieve impactful results. So I think that's actually the most exciting part of winning this award, is that they then can serve as mentors and model programs to others. I just want to point you to this slide. This year's winners were honored at a reception on May 9th, hosted by the Allergy and Asthma Network to cap off the network's annual Allergy and Asthma Awareness Day on Capitol Hill. So here you see the teams from Pediatric Asthma and Allergy Clinic, PAC, up on top, and on the bottom, the Community Asthma Prevention Program, CAP, receiving their award from John Edwards, who's the director of EPA's Office of Radiation and Indoor Air. As I mentioned earlier, I'd like to just briefly go over EPA's system for delivering high-quality asthma care. This system features essential components to developing an effective and sustainable asthma program. This is a conceptual framework that you see on the screen, and it's based on the results of the Asthma Health Outcomes Project, which was conducted several years ago by the University of Michigan. And they looked at hundreds of asthma programs and really were able to boil down to the core elements of a successful asthma program and the processes that drive their implementation, continuous improvement, and endurance. So you see in the middle those 5 key drivers of the system. They are committed leaders and champions, strong community ties, integrated healthcare services, tailored environmental interventions, and high-performing collaborations. These key drivers are the essential building blocks for a system for high-quality asthma care, which gets results, and they're used to help sustain the system. Today's speakers will explain how each of their programs, evaluation processes, and success has helped them sustain their programs for 2 decades. Taking a little bit closer look at these key drivers, today we're really going to have our speakers kind of focus, and we're going to look at these winning programs through the lens of 2 of the key drivers. The first is strong community ties. Both of these programs have been meeting their patients where they are through the community and in their homes. So you'll hear how they involve their target community in all stages of program planning. They use feedback channels for ongoing communication, and as the community needs have changed, the programs have evolved and transformed to change with them and to meet those needs. In these programs today, you'll hear how they situate offices and care sites within the target community, how they promote cultural competence by meeting the local needs, again, with local workers and community health workers. They demonstrate a broad commitment to their target community by getting involved in community affairs, and they really understand and respond, again, to the community's needs. Also, we'll look at the second key driver is committed leaders and champions. As we all know, a program is really only as good as those invested in it. And so, again, next slide. Yeah, that's it. Thank you. PAC and CAP both ensure program involvement by making sure staff and partners understand the vision, core goals, desired outcomes, and processes for measuring progress. You'll hear from both of these programs how they recruit champions and community health workers from within the community to deliver evidence-based care that's linked to desired outcomes. You'll also hear about the training they provide to their community health workers and how they're able to secure reimbursement for home visits using community health workers. Very exciting work. So without further ado, I'm going to turn it over to Kimberly Honda, who is the Clinical Director and Program Lead at the Pediatric Asthma and Allergy Clinic at Zuckerberg San Francisco General Hospital. Kimberly is a family nurse practitioner and also serves as a clinical faculty preceptor for UC San Francisco School of Nursing. Thank you and welcome, Kimberly.
Thank you so much, Tracy. Excited to be here today. Again, just to point out, we come from the Pediatric Asthma and Allergy Clinic in Children's Health Center, which is our outpatient pediatric unit located within Zuckerberg San Francisco General Hospital, which is our city-county hospital. And all of this is within collaboration of the academic site of UCSF. So I'm excited to be here today. I hope to share a little bit of insight about our program, who we are, where we've been, and where we hope to go. And I want to start by setting the scene. So the task at hand, as we see it, this is asthma in San Francisco, quite common among children. As you can see, the childhood prevalence in our city is approximately 13.8%. And when we look at our hospital, asthma historically has been the top admitting diagnosis in pediatrics and continues to be among the top 5 reasons that families seek emergency care. We know that the greatest burden of asthma falls most heavily upon our families who are low income, of ethnic minority groups, and living in inner city environments. And despite being a very densely populated city, very highly developed city, we acknowledge that there are few specialty services that exist in our community, and there are large gaps in service in these areas, especially within the underinsured population. and this is particularly true within pediatrics. Who gets hospitalized for asthma? If you look at the chart on the right here, you can see both for California as a state and for San Francisco County alike, the very old and the very young. San Francisco County, we struggle a little bit more with the 0 to 4-year-old population, so the preschool age child who wheezes. And then if you look at the chart on the right here, you can see that if we break this down by ethnicity in San Francisco County, represented by the blue bars here, Blacks were more than 8 times more likely than whites to be hospitalized or have an ED visit for asthma. And this is a similar trend to what you see across the state of California. Our geographical distribution across the city really illustrates our greatest disparities in asthma. And so I wanted to show you a map here. You can see, if you look at the map on the left, this is our city. We're a small peninsula. We're made up of about 51 different zip codes. We're closely packed together. And there was a really interesting surveillance report done by the California Department of Public Health, which looked at ED visits for asthma in San Francisco. And what was found was that out of these 51 or so zip codes across our city, ED visits for all ages for asthma were predominantly comprised of patients who came from only 5 top zip codes. And this occurred at a 4 to 7 times increased rate than that of the lowest represented zip codes. And I wanted to point out for you that those zip codes are located around the northeast and the southeast regions of our city. And if you look at this map here, you can see that that corresponds with the areas where we see the greatest concentration of poverty in our community. And then we can take that a step further by looking at the chart on the right here. You can see traffic density flow patterns mapped out. You can see areas where we see the greatest particulate matter, industrial waste because of high traffic flow really cutting across the city. These really highlight or underscore those areas of concern. And so this really shows us how zip code can determine health outcomes. And this is where asthma is no longer just a clinical issue for us to tackle, but really at this point becomes a larger social justice issue within our community. So I wanted to say a few things about how we got our start and how we've continued to evolve our program. Our clinic was established in 1999 to address these high rates of asthma that we were seeing in San Francisco County. The goal was to establish a comprehensive model for treatment for these kids living in an inner city environment. And we wanted to incorporate a safety net hospital, incorporate this service into a safety net hospital with an existing population in which we were already serving a Medicaid population. So really addressing that gap that I mentioned earlier. This is a medical social model of care. So this really introduced the community health worker into the clinical setting for the first time. And we were lucky to have an early partnership with the Yes We Can program at our local state university, which provided grant-funded community health worker positions starting in 1999. This was paid for by the California Endowment Grant. And eventually, when those funds ran out, we did heavy petitioning in front of the SF Board of Supervisors and the Department of Public Health until eventually 2 community health worker positions were approved and became institutionally funded. Eventually, as that endowment funding ran out, the Yes We Can program expired and is currently no longer offered at San Francisco State University. However, I just wanted to highlight a couple things about this program because Yes We Can is really a foundational model. And in addition to a certification training curriculum for the community health worker, which is what we utilized, the Yes We Can program provides a toolkit for clinics with a training manual, guidelines for program implementation and replication. And over the years, as our clinic has grown and expanded, we may not use the title Yes We Can any longer, but we still think of ourselves as a Yes We Can clinic. And you can see here the 4 main goals of Yes We Can, which continue to guide our mission as a clinic today and inform the work that we do now. So why the community health worker? Some of you at your sites may use health workers in different capacities. For those of you who don't know what a health worker is, the community health worker is a non-licensed community member who has completed training in health education and social support. So they have a broad understanding of community systems and they're able to move fluidly between the community and the clinic. There's a peer-to-peer element here. This really creates a secure place for even our most vulnerable families. And the CHW really has a strong knowledge base in asthma. So this is a person who becomes viewed as an expert in their community. This is a non-clinician hire and therefore considered to be cost-effective. And we believe that it's the CHW's unique ability to provide this stability and this consistency for patients that is really the key to our success as a clinic. In order to optimize this role, we've chosen to pair the CHW with the clinician at the center of our healthcare model. And so we've tried to represent that with a schematic here. This allows the CHW to float across sites and work in various capacities. At our clinic, at the PAAC, we have a multidisciplinary team approach. It allows our clinical staff who work in other disciplines to bring their expertise in. And the CHW is essential to this team during live clinic sessions, which for us happen 2.5 days a week. They interface first and the most with patients, so starting at intake and all the way through until discharge during a clinic visit. And their goal is to really bolster the message of the clinician. The CHW encourages continuity with other clinic services within our system. So when a patient is seen for acute asthma, for example, the CHW can meet with the family in the ward or in the emergency room, talk about the exacerbation, offer teaching and reassurance, help the family link back into our care, or engage them if they are newly referred. And we really feel that the CHW overall acts as a resource for primary care clinicians, both within our DPH network as well as across the community. There's someone who can provide consultation, provide trainings, whether it's one-on-one or in school settings, at daycares, or in foster parent agencies. So in effect, the CHW is really an educator, a patient navigator, and a mobile consultant across many different types of clinics. And for this reason, they're the heart of our clinic model. So how do patients come to us? We accept referrals from about 21 or so of our system-wide clinics within the DPH. Patients are seen initially for an intake visit in which we do a real deep dive. So we do a very thorough, comprehensive history. We set up referrals that need to be taken care of right away to really support the family's individual needs. Patients are enrolled in our active census. They engage with a community health worker from that point on, who becomes their main point of contact for case management all the way throughout their time in clinic. And then we see them for ongoing follow-up and medication management until we feel that they're stable enough to graduate back to primary care or their referring provider. We would like for this to take about 6 to 8 visits on average for them to become stable, but what we found is often we discharge patients and they don't want to leave our care. So we have many patients who really stay with us for a long duration of their life. And if you look at the bottom right-hand corner, you can see here, this is the father with his son. He's brought him into asthma clinic. This father was once an asthma clinic patient as a child himself. So full circle. Here's what we offer during a clinic visit. Really what we wanted to do was provide high quality, evidence-based care, but we also wanted to continue to operate with the CHW and the clinician at the core of this service. So we've really built our resources to provide wraparound care, and we wanted to become more of a one-stop shop for families who often face multiple hardships when trying to get to an appointment. You can see that we have a variety of in-house diagnostics that we can offer based on clinical need, whether it's asthma or allergy or both. Customized education is really the cornerstone of what we do. This all comes from a motivational interviewing technique in which our community health workers are able to really assess cultural beliefs and family goals as they do their teaching. It's very interactive. When we do teaching sessions, things are very hands-on so that patients can learn how to use devices and medications properly. We give out a toolkit or a toolbox with supplies that will help equip the families to manage their asthma. So maybe it's a storage box for their medications or allergenic mattress covers for a dust allergy, anything that we think is going to help support this family when they go home. And then our home visiting program is an essential component and sort of a unique aspect of our program. This is a special opportunity for the community health worker to observe what happens at home, provide an objective evaluation to identify environmental triggers like mold, pests, or structural safety issues, And then we can offer either immediate remediation or help facilitate ongoing communication with the landlord or the property manager. And this is perhaps our most active area of patient advocacy. We have a strong phone call follow-up program after each visit, which provides ongoing case management, triage, and symptom support. We support patients as they need help with referrals or pharmacy and insurance issues, because these can be huge impediments to care. And we would rather troubleshoot these issues as they come up right away instead of waiting until the patient comes back for a follow-up to us in 3 months. So we can really intervene early because of this. And then you can see at the top left here our need-based services. So this is perhaps the area that we are most proud of. We've really enhanced our services based on the clinical needs as they've developed in our population. And so we've adapted our approach to now include a high-risk asthma clinic, as well as in-house pulmonology. These are services that were established to treat those patients who suffer from frequent severe exacerbations. We found that by bringing a part-time pulmonologist into our clinic, rather than referring patients out, our show rate improved and our co-management improved significantly. We have a behavioral health team. We have a nutritionist who both participate in our team huddles before each shift. That way we can identify patients together who may need additional support. We can provide them with a warm handoff, which is a face-to-face visit, or a cold handoff, which is a referral. And then we have a medical legal partnership with our local Bay Area legal aid, which placed an attorney with us in clinic during sessions to screen for patients' concerns. They can actually meet with them one-on-one. And this is really based around the social determinants for health. They can offer legal consultation in the moment, and many of these turn into referrals. Many formal cases have been opened in this way. So again, we're really trying to provide as much as we can upfront during the visit when the patient is with us physically in clinic. In the recent 2 years, we've shifted our focus toward outcomes. We want to know if we're making a difference and how we can improve. And while we don't have a dedicated data manager, we've really honed our ability to query and have found that if we ask the right questions, we can really produce some good data. And so we've only just now begun to examine our data, but I'd like to share with you some of what we've collected so far. Looking at pediatric admissions for asthma, you can see starting at about 2014, which is when we had our peak, the average number of admissions per year was approximately 81%. If you compare this to our recent year, 2017, in which we had 62 admissions, you can see there's a 23% reduction compared to the previous 3 years. It was late in 2015 or early in 2016 when we began to really actively implement our QI strategies. And so while we, as a clinic, we cannot take credit directly for this reduction, we have to really consider seasonality and annual virology. We can postulate some of the things that we think might have contributed, and I'll highlight some of those in the slides to come. Most notably, I wanted to point out here in this red bar, you can see our data shows that for 2017, our CHWs performed education for 62 admitted patients, which is actually 100% of patients who were admitted for asthma this year. And I think this really speaks to a strong partnership that we've developed with our inpatient team, really great communication across all of our teams together. Dashboard metrics, some of you may have this available to you at your sites, depending on the type of EMR that you're using. This is a collection of metrics that really look at areas of safety, quality, and the care experience. We had over 1,000 patient encounters this year, most of which were follow-up visits for established patients. And we're happy to say that we were able to improve our referral response rate, decrease our wait time for new patient intake visits, and we also decreased our visit cycle time. Keep in mind that this is specialty care, so we started at a baseline of over 2 hours initially, as visits can be quite long. But we've really focused on our clinic efficiency, our team communication, and enhancing our workflows to reach this 18% reduction. And we will continue working toward our next goal, which will be under 90 minutes from the point of intake until discharge. This is a breakdown of our activity around housing and habitability. You can see here that the majority of these are closed cases in which we had completed repairs, but there's a fair number of cases that still remain open. These are pending cases that have slow progress because we're working with HUD or Department of Building Inspection, and so it's really difficult to make some headway in these areas. Majority of our action, if you look at some of the pie charts here, majority of our action has been in the form of letters to the landlord and referrals to our medical legal partnership or to our other community agencies. And then I also wanted to point out that in this no intervention needed group, so this 19% here, you can see that a handful of our patients are still declining interventions even though they are available to them. So this includes patients who had no findings, but also patients who were offered services but declined. And there are various reasons we can postulate for this. We can talk more about this in the forum afterwards. This is a new addition to our program in 2016. School advocacy program allows us to identify and track concerns around albuterol and EpiPen being given at schools. We were able to establish a point of contact with schools in order to intervene when there were issues. And here you can see the three most common themes that were reported in 2017. This was a major gap because we found a lot of parents had concerns that weren't being addressed, and these would just continue to develop unless we had someone who could actually communicate directly with the school staff or the school nurse. And so this is something we hope to, in our next steps, address by offering training to some of these school sites. We've enhanced our efforts to reduce secondhand smoke exposure by offering CEASE. This is a great program that offers a brief intervention where we can prescribe nicotine replacement therapy and offer a referral to a quit line. We're happy to say that of the referrals we made this year, 67% of those patients referred actually completed the counseling that was recommended to them. This was such a successful pilot in our clinic that this CEASE program was eventually rolled out to other pediatric clinics, so our inpatient unit, outpatient unit, and nursery. And although numbers talk and we love our quantitative data, I wanted to include some patient feedback because I think that this is really going beyond what we see in numbers and really speaks volumes to the impact of our program. You can see some quotes here about services, including really engaging with a community health worker, being able to speak the same language, feeling respected and valued, having so much fear about asthma and being able to go home equipped with knowledge for the first time, feeling very thankful for our team because we are able to communicate with patients between visits, not just while they're with us in the clinic visit itself. And then I particularly like this one in purple here, which really highlights how much of a difference it can make to inform families about how they can take care of symptoms at home, perhaps reducing utilization of the emergency department in times of acute asthma. So how do we ensure longevity of our service, and where do we go from here? I've put this together so that we can really look at some of the obstacles that we've faced over the last several years as we've grown our service and how we've worked to turn those into opportunities. So things like physical space, having enough room to see patients, staffing, these are things that are often subject to changes in our county budget and have been significant limitations for us in the past. When it comes to rooms, we're often sharing with other clinics that are scheduled during that time. But on the flip side of that, as a positive, in some ways we're able to share resources that are already equipped within the hospital. So for example, we may use phlebotomy from primary care one day, we may share a nurse from urgent care another day. Really helps us sort of utilize and optimize the resources that exist around us. Staffing has always been a struggle for us. It ebbs and flows based on budgetary constraints. Historically, we relied a lot upon volunteers to help fill in those gaps. And as we've grown as a clinic, we've been able to justify the presence of other salaried positions, even if they're part-time, for example, with our in-house pulmonologist. And so we're happy to report that now our highest risk cohort is actually seen by a clinic run only by faculty, so there's really great consistency there. And we have less dependence on volunteers now. Community health worker positions have always started out as grant-funded positions. So initially, like I said, we only had the 2 positions that were grant-funded. Ultimately, we were able to get them institutionally funded. Fast forward to today, after the last 3 years, we've been able to also approve funding for a permanent position for a 3rd CHW. And so now we have 3 full-time, fully funded CHW positions, and we have now shifted our focus toward providing continuing education to really improve retention of those community health workers. Billing is a complicated issue because we are embedded within a hospital system. Patients who are seen for medical visits in-house are billed as ambulatory specialty care visits. They're reimbursed by Medicaid, so some are per visit, some are capitated, and then we receive additional reimbursement via FQHC designation. However, there are some gaps, so some of the off-site education that is done, which includes our home visits, remain unbillable. And so that cost is currently absorbed by the Department of Public Health. So we really have to shift our focus and look at other opportunities for grant and donor funding to help bridge those financial gaps, working with our community partners and other acknowledgments such as this really help increase our visibility and help us to collect some important ties in terms of finding those funders. Patient dynamics are difficult to predict. No-shows are inevitable, especially amongst our population. There's a new trend in the last 2 years, I think, considering we have such a large immigrant population, and also considering our current political climate. I think many patients are choosing to decline services and interventions that are offered. And so we've really shifted our attention toward case finding, so looking at ways to actively identify and recruit patients from other clinic settings who need asthma-related services. And our CHWs work really hard at re-engagement for those who are lost to follow-up. And then because we're a public hospital in an academic teaching institution, we're constantly working to balance these two priorities. So we want to achieve efficiency in the clinic with an excellent patient experience, yet we still want to provide a robust learning opportunity for our clinic trainees. And so our association with UCSF in an academic environment has helped us improve our viability and our longevity. And we've become a desired research partner and a site for recruitment for multiple studies in this way. It's this ongoing provider education that we can provide, and also teaching conferences both for our staff and our trainees. We have NP and med student rotations in 50 to 75% of our clinics, which help us encourage guidelines-based asthma care. In an effort to promote system-wide changes, we've begun to use our platform toward action, and this is where our community partners really come into play. We've provided written legislative support to help promote policies which will improve asthma care. And I wanted to include this really powerful quote from one of our patients who had such a moving experience with her community health worker. This is the patient himself, the kiddo in the middle there, with his mom and his dad. The family was so touched by their experience with the community health worker that they were willing to drive all the way up to the Sacramento Capitol and testify in a formal hearing in support of legislation that would support funding for community health workers. And so things like this are what really shows us the heart and soul and the drive behind the community health worker and how much it can really impact our families. All right, so when we look at our asthma horizons in terms of where we want to go next, there are a few things in clinic that we're hoping for. We would like to continue the chronic care model in the form of group-based visits, so especially for those new patient initial intake visits. We are continually working on enhancing our allergy services, so especially around food allergy or procedural-based clinics like early peanut introduction, food challenges, for example. And then we will continue to work on piloting QI projects. So again, really taking the next step in terms of what we can do with data evaluation. We're currently working on some small and large-scale projects, both with UCSF and within our own San Francisco Department of Public Health. And on a larger scale, we hope to continue every opportunity to support CHW reimbursement, both because it's such an important issue and also because it remains a huge financial gap for us. And all of this we do in an effort to continue fostering a robust program that really optimizes patient care and can be further replicated at other sites and institutions. And we will continue to strengthen our collaboration with our community partners. Our partners, and I've listed some of them here, really act as a resource for us, as a community forum. Like I mentioned, they really increase our visibility of some of the most important issues in patient care, especially when it comes to asthma. And so we share this award in part with them as well. And so with that, I think I will close. This is a picture of our team enthusiastically signing off. But on behalf of the Pediatric Asthma and Allergy Clinic at Children's Health Center, UCSF, and the Department of Public Health, we thank you for your acknowledgement and your time.
Great presentation, Kimberly. Thank you so much. So rich and so robust. There's so many nuggets I want to pull out, but in the essence of time, we need to move on. So at this time, I would like to introduce Dr. Tyra Bryant-Stevens, who is a board-certified pediatrician in primary care for over 30 years. In 1997, she founded the Community Asthma Prevention Program, CAP, at the Children's Hospital of Philadelphia. And again, this program uses community health workers as well and resides to implement asthma interventions in underserved, poorly resourced inner city communities. So take it away, Tyra.
Good afternoon. In the interest of time, I will kind of go through these slides fairly quickly, but also open to questions in the at the end. About 20 years ago, as a primary care pediatrician in West Philadelphia, one of the top urban primary care practices, I realized there was a gap between providing guideline care in the clinic, what was happening in the community, because despite us using asthma guideline-based care, our children still ended up in the hospital and the emergency room. So we founded the Community Asthma Prevention Program with the following goals: to increase asthma knowledge and to improve asthma self-management behavior, to improve quality of life, to equip members of the community to become neighborhood asthma experts, promote asthma-safe home and school child care environments, and to reduce the burden of asthma on the disparate populations in Philadelphia. This next slide shows the screening that we did, where we went to over 2,000 doors, and I should say the community health workers did this work, and this was published in 2012. And what we showed is that if you looked at the zip codes in West Philadelphia and North Philadelphia, which have the lowest income neighborhoods, that there's a really varied but also very high prevalence of doctor or healthcare provider diagnosed asthma. And we find that now that we have the electronic health record, that this still appears to be true in the sense that 26% of our inner city practices, the children have a diagnosis of asthma, with 19% having active asthma, meaning that they are being managed chronically and currently with medication. Also, if you look where we are in terms of the national and local morbidity, you can see that nationally we are about twice as, our hospitalization rate is about twice as high as the nation in general, even for African American children. Most recently, we, utilizing our electronic health record data, we were able to map out hospitalizations and emergency room visits for asthma. And this is just West Philadelphia, but it's interesting to see that the darker lines are the highest hospital and emergency room rates, and that they're very similar in terms of neighborhoods. And what we surmise from this is that hospitalization emergency room visits are more closely related than we thought, and maybe it has something to do with housing violations. So we then mapped on top of the hospitalization emergency room rate, L&I violations, licensing and inspection violations, and in the green areas you can see that's where they overlap. And again, it's very similar among hospitalizations and emergency room visits in West Philadelphia. And I should back up and say that Children's Hospital is in West Philadelphia, so we are really trying to address asthma on a population level in this community. So what are our building blocks? Community outreach, optimized asthma care, advocacy, and of course, research. Our community outreach includes employing community members, community health workers to implement asthma evidence-based interventions in our low-income neighborhoods. Also, we partner with other community groups, such as schools, faith-based organizations, daycares, and primary care centers to identify children at risk and to provide educational opportunities. And finally, we engage community members to help us translate and to adapt evidence-based studies through our CAP collaborative. In terms of optimized asthma care, as I stated before, we have 3 inner-city clinics in West Philadelphia, and within those clinics, we do provide guideline-based care. But in addition to that, we provide self-management education to caregivers and children in all settings, and we use low literacy education materials. We promote guideline-based asthma care in the home, school, and primary care office. We also provide patient-centered care coordination that facilitates high-quality asthma care in the home, school, and primary care office. And finally, we try to connect families with community resources such as housing and transportation and scheduling appointments with their primary care provider. Obviously, we want to make sure that what we do really works, so we apply the principles of community-based participatory research to implement these evidence-based interventions. We utilize principles of implementation science to also understand the ability to disseminate asthma interventions, and we seek cost-effective methods to implement these interventions in order to promote sustainability. Our advocacy runs in the national and local arena. We participate with national organizations, most recently with the Allergy and Asthma Network, but we also participate with our city and statewide efforts. And our partners in our collaborative, we leverage the resources that they bring to the table along with what we bring to the table in order to promote advocacy. And we also promote caregiver and patient engagement to advocate for their needs themselves, because ultimately we want to equip them to be able to state their needs and to have their needs met by both federal and local government. So what are our core interventions? We conduct community home visits, community asthma classes. We train parent educators to actually facilitate our community asthma classes. We provide asthma education in Philadelphia schools, and we educate primary care physicians to integrate asthma guidelines into their practice. We have a community of stakeholders. I didn't name our stakeholders, but just to give you the grouping, parent and caregivers are at the core of our stakeholders. We always want their voice to be heard and to be the center of what we are trying to do. Obviously, children with a diagnosis of asthma are also very important in terms of our stakeholders. Clinicians, school district professionals, community agencies, faith-based organizations, and housing agencies have all been partners at some point along our 20-year journey. And nothing could have been done by CAP without this partnership, so we really value the expertise that they bring to the table. Our current CAP staffing includes 9 community health workers, 4 of which are asthma navigators, and these are similar to the previous presentation integrated into the primary care health team at CHOP, inner city practices. We have home visitors who are community-based and can serve all of Philadelphia inside and outside of CHOP patients. We have a CAP program coordinator, a CAP research project manager, a nurse, asthma care coordinator, research assistant, and the medical director. And here's a picture of our team. We're currently working to integrate and to implement all of our interventions. I'm not going to go through this, but just to show you that over the last 20 years, we have really worked the gamut of different interventions, from community interventions to individual interventions. We've also worked with the school district. We've recently completed an adult asthma home visit study with one of our partners at the University of Pennsylvania, and currently we are now combining CAP with major home repairs in order to further improve the lives of children with asthma. So it's always important to get community feedback, and here are some of the things that have been said about our program of the year. In terms of our classes, since taking CAP asthma classes, I've learned so much, but the most important thing that asthma can be controlled, and truly that is the center of our messaging, is that you can control asthma, and we hope to help parents and children learn how to do that better. From the provider here, I'm telling parents about CAP because you are the best secret in Philadelphia from the parents about home visits. Since my home visit has been coming weekly, my children haven't been in the emergency room in the past year. And also from a parent, we do not panic. We have learned to act quickly and calmly before asthma attacks occur. So I'm going to focus on our home environment education interventions, since that's the focus of this award. We have community health workers who are trained lay health educators who implement intervention, conducting on average about 7 visits per family over 1 year. They assess child's bedroom, general living areas, and then they teach parents how to make simple environmental interventions in these areas. We also give supplies. We inspect the rooms for maintenance of the interventions that follow visits, and at each of these follow-up visits, we also reinforce education with Teach Back, and over 4,000 families have received home visits, and we've in fact conducted over 20,000 home visits over the past several years. We're often asked about how we train our community health workers. There are 3 major ways that we think about training. The first is didactic with active review. The second is to have some mock training sessions. And the final is field training. I'm not going to read through each of these, but just know that it's about 40 hours in office and about 40 hours outside of office. But that includes smoking cessation training. It includes motivational interviewing training, as well as integrated pest management training. And where are community health workers now? Well, they're everywhere. They're in the community, they're in the primary care center, they're at home, and they're engaged with both the child and the family with asthma. So as we start to think about this, in 1998, we started a home visit program, and then about 7 to 8 years into this, we began to realize that our community health workers were in the community, and obviously we communicate with the primary care provider, but we wanted to be able to integrate them more into the office setting. And the reason that we thought of this is that studies have shown that tailored asthma interventions do work, and that it may work better than health insurance and access. They also had shown that community health workers were effective in delivering tailored interventions. Recent studies have shown that community health workers could be integrated into the patient-centered medical home, and then we wanted to finally reduce utilization by expanding the role of the community health worker in the medical home, that is the primary care office, while maintaining their visibility and interaction with children and caregivers in the home and community. So we designed the Asthma Navigator Project to close the circle of care between the home and the clinic. They're assigned to the primary care offices in the inner city, and they have 3 components we'll talk about. They also make home visits. They help parents to determine care coordination goals, and then they give resources or point them to resources to facilitate care coordination goals. They assist with scheduling for primary care office and specialists, and we follow for up to 1 year. So in this study that I'll show you some outcomes, we enrolled 0 to 17-year-olds with 1 inpatient or 2 emergency room visits in the past year on at least 2 controlled medications, and they had to be in one of our inner city practices, as well as being Medicaid or CHIP insured. Our components of the Navigator program includes care coordination, education, and navigation. Care coordination, especially around increase in follow-up visits, because what we saw with our children with high utilization is that they weren't making it back to the primary care office, but also to improve patient and primary care physician communication. Education was similar to what we had done in the homes, but also included in-office review of medications, devices, and the asthma action plan. And then with navigation, we did a baseline needs assessment, identified resources and referrals, and also connected them with specialist visits. Here are the 4 visits that we do in the home, and here are the education topics, as well as environmental interventions that we do. So we enrolled 254 children with about a mean age of 5. And as you can see, most are male and African American. About 22% felt unsafe, 27% saw violence in the neighborhood, and most of them were Medicaid insured. So our outcomes, as you can see in this, include symptoms and quality of life outcomes. And what we saw is that rescue medications, daytime symptoms, nighttime symptoms was reduced by over 50%, and float activity also by 50%. But school days missed and work days missed was dramatically reduced by over 70%. So we saw a real value in integrating them into the primary care center. We also continue to do what we've been doing for years, which is looking at triggers and remediation for these families. And we saw that with cockroach, pests, and mold, a big reduction in the presence of that. And we also saw that parents were taking more steps to remove those triggers for cockroach, pests, and dust. Mold is still a big problem because it requires professional remediation in many cases. In terms of utilization, we saw a great reduction in unscheduled visits, emergency room visits, and hospitalizations, all which were statistically significant in this group at 12 months. And then we had a University of Michigan health economist look at the cost for this population. This was something that he did outside of our study and was actually funded to do this through our funder, not through us. And what he saw was a huge reduction in cost of about $10,000 per patient. And I wanted to just bring this home with a case study. We have AB, who's a 12-year-old, who has uncontrolled asthma, non-adherent, and several no-show appointments. He's also had many emergency room and inpatient visits. At the time of the visit, the Asthma Care Navigator's goal helped mom to identify her goals, which were to get the child to take his medication every day, to be able to monitor it, and also to remove asthma triggers in the child's home. So the Asthma Care Navigator enrolled the child, made an appointment within 2 weeks, identified the triggers in the home, and at the second visit, she went when the child could be home and did the trigger and medication class, focusing on the roles of control and rescue medication. She brought towels because the caregiver agreed to remove the very worn carpet from the child's room. After that time, the child began to take his medication twice a week but forgot the rest of the time. On the third visit to the home, the towels had been laid, and the Asthma Care Navigator brainstormed with the child about another way to remind him to take his control and medication. They decided to use the calendar, and then mom would be able to check in to remind him if he forgot his medication. So the good news is that a month later, he actually made a visit to the office, and he reported that he remembers to take his medication 5 days out of the week, but he's still shooting for every day. In summary, the navigator was able to help mom with removing triggers, making a follow-up appointment, and was able to help the child remember to adhere to treatment. So finally, I wanted to end with lessons learned in sustainability. We have realized over the years, and actually it didn't take long to realize how much the community members contributed to our collaborative, and that we had to really value their expertise in order to create feasible, acceptable, and sustainable interventions. We realized that the participatory process was essential to community engagement, and identifying resources in the community helped us to establish where the strengths are in the community. And it's important to remember that even in low-income communities, there's strength. And then sharing outcomes with partners is important for interpretation and application of findings. In terms of community health workers, we realized how helpful it was to have these peers, and that they really help to facilitate the connection between clinic and home because the parents trust them. They know they can call them at any time, and they know that they can call them to help them schedule appointments as well, which can be a big barrier. We found that the asthma champions, both physician and nurses champions, were really important to the Asthma Navigator integration into the clinic. Also, we really worked on maintaining data integrity so that we would be able to report our findings. And then we found that this evaluation actually led to our sustainability. Currently, we do have payments for home visits. There are 4 home asthma navigators are totally sustained and on our operational budget. And what we've learned is that we really had to think about sustainability from the beginning of the Navigator project, which when we first started, we really weren't thinking about sustainability 21 years ago, but thinking about it and actually making sure we had outcomes that spoke to the Medicaid managed care offices and the organizations was really important to promote sustainability. Also that we had to encourage our community partners to think about it as well in terms of if they want us to be in the community or in the school, that we had to think together about how to sustain this. And then looking for partners within our own organizations with whom we could combine and leverage our strengths and resources. For example, we use our social workers who are already on staff in the 3 inner-city clinics to support the community health workers in identifying resources or dealing with problems such as domestic violence or child abuse. And we, of course, remember it always requires some funding. So in summary, we found that integration of community health workers as asthma navigators really did help to improve outcomes, and that navigators also promoted national asthma guideline-based care in the home and the office, which resulted in reduced symptoms and healthcare utilization. And this value added has been acknowledged by the practices in that these are sustained positions right now, and by the insurers because they now pay us for the home visits. We are still working on housing. We realize it's a public health problem. We have now started to work with our housing organizations to actually do major home repairs for some of these families outside of the very simple interventions that we do with our community health workers and home visits right now. And our final step towards closing the loop is now to connect all 4 sectors. So we've been really successful in connecting the home and the clinic and the community to some extent, but now we plan to connect the schools. And we're currently conducting a study called West Philadelphia Controls Asthma, where we are recruiting children from the low-income neighborhoods. They're receiving services based on the randomization. This is the factorial design. If you look at the squares, kind of the blue squares, a quarter of the children will have a community health worker in the primary care center as well as in the school. A quarter will just have a community health worker in the school. A quarter will have community health worker in the clinics, and a quarter will have usual care. In addition, we have the 20 public schools in West Philadelphia randomized to for 10 to receive that school community health worker and 10 to not receive community health worker. Within the schools, we are implementing evidence-based programs, which are in the green box: open airways, school-based asthma therapy, classroom environmental remediation, and care coordination. In the clinic, we are implementing Yes We Can, which was previously described, CAP home visits, care coordination, and school coordination. And we hope that at the end of the day, we will be able to convince payers as well as our institution that it's important to support the work of the community health workers both in the clinic and in the school. Thank you for this acknowledgement of our work, and thank you for the opportunity to present our work to this audience.
Well, thank you, Tyra. I know we're a few minutes over, so I thank you to the audience, too, for hanging in there with us. I think you'll agree that both presenters had a wealth of information. We could have probably taken another hour. But before we close, I just want to take 1 minute, if you could indulge us in answering this last polling question. Based on what you heard today, what steps are you more confident that you'll make in the future? If you would please just take a moment and select all that apply. So this question, you can select more than one answer, please. Great. Many of you will be going to visit the Hall of Fame at Asthma Community Network. Many of you will be investigating potential partners, looking at tracking, and more than half of you are looking at researching sustainable financing options in your state. So that's very exciting. So to help you do that, next slide, please. Just very quickly, again, I'd like to point you to Asthma Community Network in order to help you obtain resources on many of the points you heard about today. So if you'll look at, just quickly, I'll go through these slides, sustainable financing and sustaining your system. If you go to AsthmaCommunityNetwork.org, you'll find lots of information for organizations seeking to pursue sustainable financing options. To help you make sense of all of that information, there's actually a Financing In-Home Asthma Care microsite, again, on AsthmaCommunityNetwork.org, and you'll see some of the focuses of the site and some of the information that you'll be able to learn more about. Again, the value of home visits, much of what you heard about today, effective reimbursement strategies, and how to make the case to your funders, which I think both of our presenters did a great job in talking about making the case and cost benefit. Lastly, community health workers. You heard about how really community health workers are the heart and soul of both of these programs today. And on Asthma Community Network, again, there's information to help with programs who are looking to train their community health workers. There's a lot of information and a movement on standardization and certification of community health workers. And there's, again, previous webinars on some of these topics. So with that, I know we're a few minutes over. I hope you found this presentation exciting, educational, and hopefully you're wanting more. And so to be able to access more information directly from our speakers, I'd like to point you and remind you of how to access AsthmaCommunityNetwork.org. We invite you to join us for the next 20 minutes or so while our two presenters are available to answer your questions in real time. And then I would just like to remind you that the discussion forum is there 24/7, and so the questions and answers will be posted there for you to access in the future. If you think of a question next week, feel free to come back and visit the discussion forum and post your question, and we'll make sure that our presenters will provide you an answer in the future. As well, I'd like to remind you that this webinar will be posted and archived on Asthma Community Network probably in the next week or so. So if you have colleagues who were unable to join us today, or if you'd like to go back and review the information, you can do that on AsthmaCommunityNetwork.org. Again, I thank you for your patience as we went a little bit over, but we look forward to chatting with you in a few minutes on the discussion forum. At this point, I'd like to say thanks to both of our speakers, and we will close the webinar now. Thank you.